All right, happy eating. No, not even funny, not even close. Okay, so it's a pretty tough crowd. Thank you for being here. This is our, or at least my second time attending this fabulous event. And we really want to thank LACMA for putting it on and allowing us to get together, share about what's happening. Before we go into asking questions of our panel, I just wanted to give you some context around what's happening in Sacramento and why it is so important for the physician community to unify and act as one voice. When we talk about politics and government and legislature, one person does matter. But it matters a lot more, significantly more, when we're able to collectively have the voices of 43,000 members. And so luckily, CMA, through the leadership of our physician leaders at our board level and at our House of Delegates level, have pushed forward and pushed policies that allow us to be at our biggest in terms of our membership population ever, and we hope to continue growing, and we want people to continue to join and unify. So when we talk about sort of what is the wacky legislature of California doing, I think in part we don't know. And what I mean by that is single payer, universal care has been the largest discussion that's been happening for essentially the last 2 calendar years. The legislature, if you look at the 2 houses, the Senate pushed through a single payer proposal that for all intents and purposes was just a shell of a proposal and a statement of principles. The Assembly took a different approach to that, and they held hearings with select committee members, select committees. Those hearings were chaired by a dentist, Dr. Jim Wood, and a physician, Dr. Joaquin Arambula, representing places in Northern California, Jim Wood, Central Valley, Fresno, Dr. Arambula. And they went on sort of a statewide tour over the months of November, December, January, and February. They'll be putting out a report on what happened in those hearings, what are some findings and recommendations. We expect that report to come out in March. In anticipation of what that report may or may not say, there's about 20 what we call spot bills in the legislature. Spot bills are just bills that express the intent of the legislature to do something good at some future date. So we are waiting to see what that report says and what bills come out. But the notion of getting universal access and universal coverage for every single Californian, regardless of ability to pay and document status, will still continue to be a conversation that's happening in the California legislature, not just this calendar year. It's a major portion of the gubernatorial debate that's going on. If you have or have not been following that, I would ask you to start following that, because healthcare is the central driver of what differentiates the Democratic candidates. So we'll be talking about that for years and years to come, and making sure that the physicians are at the table to help craft how that policy works is absolutely critical. I know it's one of your breakout sessions, but opioids and the opioid epidemic continues to be an issue that is garnering legislative attention. And legislators love telling physicians how to practice medicine. So the notion of pill caps has already been introduced. The notion of minors having to consent to certain things has already been introduced or thought about. Notions of physicians having to continuously write down justifications in patient records has been considered. And so we'll be fighting a lot of those issues, and at the same time fighting for real solutions, which are providing people access to treatments, because there's some barriers that health plans have put in place for people battling substance abuse, such as prior authorizations for those kind of services, or all-time, lifetime caps on how many times someone can access those services. So we'll be pushing for real solutions with regards to that. In a variety of issues, mandatory screening has become a really good idea in the legislature. That is sarcasm for all those that are eating. Second failed joke. Okay, this is going to be interesting. But mandatory screening has been a solution that the legislature has wanted to put forth, particularly in the Central Valley. They're worried about valley fever. Lead has become a really big issue, mostly because in the Medi-Cal space, Medi-Cal recipients are supposed to automatically be screened for lead, and the legislature has discovered, shockingly, in a government program, all the requirements of the government program aren't actually being followed. So they'll be looking at that. The other major focus that we'll be looking at is the actual effective and efficient and hopefully easy rollout of the bonus payments related to Proposition 56. It got tied up at the federal level with some approvals. We've seen some drafts with regards to all plan letters for those enrolled in the Medi-Cal managed care space. So hopefully those dollars will be rolling out soon. If you're in the Medi-Cal fee-for-service space, those bonus payments should already be rolling out to you. So our folks are still, and by that I mean CMA staff, continue to look and monitor at that and continue to advocate for a smooth implementation process with our state and assembly budget committees. The last thing that I will mention, and then we'll sort of ask some questions of the panel, is the second portion as it relates to physicians of Proposition 56. And I know you don't remember because you're like most voters, they don't really remember what happened on the last ballot. But we passed the Proposition 56 that increased the tobacco tax by $2. And in addition to providing bonus payments for physician services, it also set aside $40 million for increasing graduate medical education slots, residency slots in California. The governor, Jerry Brown, did a swap with the general fund for that money last budget year, and we're poised to push against that and actually get that swap corrected this budget year. So we'll be asking folks to, again, band together and push on that because, okay, it's just water. Because if we don't, we won't be able to effectively address workforce issues here in California. As everyone knows, there's a physician shortage. Not only is there a physician shortage, there's a physician maldistribution, and we have to get serious about how to correct both of those things because it'll have tremendous impacts on the delivery system, not only now, which is it's having impacts, but really, really into the near and far future. So with that, sort of setting a context of what's happening in the legislative realm, I'm going to look to Dr. David Azis, our president-elect, and tell us, as the incoming CMA president, what are your top priorities for improving health care in California?
Thanks, Janus. So I think we all recognize that under the current administration, there has been a generalized diminution of the effectiveness of the ACA. Whether you were a fan of the ACA or opposed to the ACA, I think we all have to agree that we saw increased coverage for a significant percentage of our population that really wasn't covered in the past. And so one of the goals of my presidency will be to ensure that we have that universal coverage for our patients, that we have that universal access, whether it's in the form of California taking its own legislative proposals to ensure that, or whether it's pressure on the federal government to ensure that the funding for the cost-sharing reductions and things of that nature that have been threatened and that are part of the important fabric of the coverage and safety net for our patients, that's going to be a critical issue during my presidency. The other issue that I think we all need to recognize is this overlying issue of physician burnout. I think many of us who are in our own practices feel very overburdened, whether it's by prior authorizations or whether it's by the demand for our services. And I think if you look at that, that's also in some ways an advantage for us. The keynote speaker from Athena Health pointed out that there's going to be a shortage of primary care physicians alone of over 8,000 in California in the coming years, and that didn't include specialty physicians, where there'll also be a significant shortage, and that will be to our strength and to our power. So as these payers continue to chip away at our reimbursement and chip away at our independence and chip away at everything that makes us feel like professionals, we have to remember that we retain that power. And I would encourage everybody, in the words of Nancy Reagan, to just say no. And so at a certain point, we have to recognize our ability to turn down contracts that are anathema to our ability to take care of our patients and our practices, and feel empowered by that. And then lastly, we need to see participation by physicians in our political process. That's critical. In the not too recent past, I had an opening in my assembly district, and every local powerful politician had their chosen candidate who they wanted to assume that position. Neither CMA nor LACMA could come out and endorse any one of those individuals because they were fearful of antagonizing all the others, depending on who actually won the election. So I held a personal fundraiser at my home for one of the candidates. That candidate won the election and became a very good individual for us in the legislature for physicians' issues. Now that individual has left office, and we have an open primary again in my district, and I've had to make a gamble. Who will I pick? And see whether, and hopefully that individual is going to get elected. So I've picked one out, and I'm pushing him, and hopefully we'll be successful. But you establish relationships that way, which are very important to CMA and to LACMA in ensuring that our legislative agenda is passed. So I would encourage you all, go to fundraisers, talk with your individual candidates, become involved. I was in Washington, D.C. about 2 weeks ago, and when I walk in my congressman's office now, everybody knows who I am. You go down the halls of Congress, and all you see are large groups going to meet with various representatives and senators. But when I walk in my personal representative's office, the receptionist knows who I am. They get his health legislative aide out immediately to come talk to me, and she ushers me in to meet with my congressman. And although my congressman doesn't seem to be particularly interested in health issues, ultimately that influence is of aid to us. And so I strongly encourage you to stay involved in the electoral process. We certainly have a vested interest in doing that.
Excellent, excellent. Dr. Flores, can you give us one thing in the healthcare system that you would change, and then can you give us a proposed solution on that would lay out how that change should occur and how physicians could participate in that change?
Well, that's a good question. I think the key would be transparency. So much of healthcare is driven. If you think about the payers, Medicare, commercial plans. Now we have the exchange, Medi-Cal. Each of those components is very vulnerable to lobbying and people jockeying for their own self-interest. And a lot of the deals get cut behind closed doors. And we as physicians are always the last to be considered for any kind of distribution of dollars. And if you think about, I call it cartels. Healthcare is run by cartels. And whoever has that power, they can manipulate those different payers. And if you look at who the top three are, it's pharma, health plans, and hospitals. And that's the reason we need to make CMA stronger. CMA can be our cartel as well. And it would be a cartel that would protect our cause, which is serving our patients. So to me, transparency is a big issue. And I think in terms of how we go about that is really to use the force of what we know best, which is all these policies and how they impact our patients, is to go to our elected officials, tell them the stories that we know best. Number two is to engage in policy that not only influences legislation, because it's one thing to get the law passed, like we did with Prop 56, the tobacco tax, but it's another to make sure that the agencies entrusted with carrying out the intent of the people is actually done correctly. And we found out that the governor had no intention of spending that money the way the people of California wanted it, which is to pay for physician services, among other things. And it took work that we had done, and I want to give credit to Gustavo, who 18 months ago said, we got to start developing relationships with elected officials who down the line are going to be influential in protecting our ability to serve our patients. So a group of us met with elected officials like Kevin De Leon, the Senate Pro Tem, although he'll be stepping down. We met with Anthony Rendon, the Speaker of the Assembly. We met with Holly Mitchell, an influential member of the state Senate. And on. We met with a whole bunch of people to introduce ourselves and explain to them what we did. And as a result of that, when the governor took the money to use it for other causes from the tobacco tax, it was Anthony Rendon who got the Assembly to nearly unanimously tell the governor, you got to put that money back in. Number two, then Kevin De Leon made sure that the Senate supported that. So it was developing the relationships, it was strengthening those relationships, and ensuring that there was transparency. So to me, transparency is the key.
Okay. Dr. Sharma, most people, or one of the things that we always hear sort of in the conversation about healthcare, especially around elected officials, is the cost of care is too much. The cost of care is too much. How do we get cost containment? So what do you think can be done about costs, and where should physicians put their voice and their efforts in terms of how to control costs and how to improve quality in that conversation?
Oh, thank you, and good afternoon, everyone. We know that the cost drivers are enormous, and there's so many sources of cost drivers within the health system that it's really hard to, sort of hang your hat on one particular issue. And so, in looking at this sort of from a comparative health economics standpoint, you can think of things like, is it physician salaries? Is it the pharmaceutical industry? Is it the device industry that's really driving it? But actually, when you look at the differences really between economies in different countries, actually really it boils down to administrative costs. That seems to be the biggest driver. And I think a lot of organizations have been making very big strides in reducing their administrative costs because that ultimately is a cost savings, to the consumers. But that's not the whole picture. Right now, we don't have leverage against a pharmaceutical industry. How do they make their money? Well, they have to do it in a private way. They have private equities. And if they're beholden to their shareholders and they have to maximize shareholder wealth, certainly they're in the business of making big wins, taking big risks, and ultimately passing on the cost of that endeavor, back to the consumer. And so it becomes a vicious cycle. And so what can we do? We can call out transparency, and we can ask for them to be transparent with their process so that we can make public, the mechanism by which they have enormous profits. However, if there's no other competitor out there, then so what? You can call them out, but they're going to maximize what they're going to do anyway because they simply have the leverage to do so. And so in the field of advocacy, simply saying that we want transparency is not going to be enough. I think what we're really looking for, are to defend or create policies that are much more mechanistic in enabling competitors to rise to the top. So we hear more and more about disruptors. We hear about the Amazon, Berkshire Hathaway, JP Morgan Chase coming together. We hear about smaller companies that sort of float to the top, Cirque du Soleil coming over, Ringling Brothers. We've all had examples of things that started off small that got big that ultimately pleased the crowd a little bit more. And so I think that's what we really need to encourage our legislators and policy creators to do is that how do we actually create a field that creates more competition in that space to drive down cost. And so I would say that that's one area where we as physicians can have leverage. But with regards to other aspects of cost containment, that also has to do with us cleaning our own house. So for example, there was a study that was recently published on CT scans being used to evaluate syncope. Someone syncopizes out in the field, they get brought in, and then they get a CT scan looking for a PE. Now that accounts, the CT scans that they order account for less than 1% of the mechanisms for the syncope. So why do we get such things? This is just one example. We have so many examples. All of us in different specialties know, where the waste lies, within our own fields. And so choosing wisely campaigns, getting behind that and augmenting, those sorts of things, figuring out, what we need and what we don't, truly need, within our own profession, that's well within our wheelhouse, and we need to dictate more of that. And so, again, we can contain costs in that regard and then make sure that we take care of our patients better. The last point I'd like to make is that, there are industries out there like Southwest for example, where they actually put their employees first. They actually say the employees first, and then the passenger is second. And so what does that mean? We have to actually think about this. Now, when we said patient-centric, what we really meant back in the time that we were introducing the concept is that, yes, we weren't taking care of our patients as well as we could have, and our systems weren't as well designed to take care of patients, and they were often subordinating to the needs of the provider. But the question is, has the pendulum swung too far? We've seen that with the opioids, and so now the question is that have we not taken good enough care of our providers, and burnout obviously is a consequence of that. I think we should probably re-examine the practices that allow the physician to take better care of their patients, not lose focus and not get so burnt out, and I think that also will ultimately translate into better care. You'd be surprised how much you can accomplish just with your hands and your voice that do not require medications, and I'm sure by increasing trust between provider and patients, we're going to see another mechanism, of cost reduction. Thank you.
Excellent. Wait,
This particular study was just simply calling out that getting a CT scan to rule out a pulmonary embolism to evaluate syncope had a very low yield, so almost less than 1% yield. So it was just as an example, to show where certain practices we have to root out and figure out whether there's value in them or not.
Okay. We'll have time for questions, but it seemed like there were some questions specifically related to this topic, so I'm going to take like a 2-minute pause for questions and comments. So I saw a hand in the far, far back. Yes, you, sir. You got to speak loudly because they weren't ready for me to do that, so the microphone's coming.
Of which there's several thousand in this state that cannot get licensing. Some of them are foreigners that have passed all their exams. Some grew up here in Los Angeles, went to UCLA, but were passionate about practicing medicine, couldn't get into a medical school here. Did go to an accredited medical school in another country, and because of the requirement for one-year residency, which is virtually impossible to get for them, they sit in limbo, unable to practice medicine. There is a pilot program at UCLA to address that, but it's a very small program, and there's literally thousands of these physicians who are in limbo, and they can't become PAs very easily or NPs, and they can't practice medicine. When you talk about physician shortage, we literally have thousands of trained physicians, some of which were actually in private practice in other countries, some of which were just new medical graduates. But because our medical school system now graduates 1,500 medical graduates annually, greater than the number of residency positions, they have no chance of fulfilling the one-year training requirement in this state. Can you address that? I know that there's a little bit of a broader pilot study bill by our legislator Arabula, but can we speak to that issue?
So just to give a little more context, so that was a pilot program. Dr. Joaquin Arambula, the legislature mentioned earlier, is running legislation to make that permanent. I'm going to ask Dr. Flores to address your question in the context of, as Dr. Sharma was talking, it seems like there are some things that government can do. There are some things that physicians can do. It seems like an area where government can sort of play in, and then sort of talk about it in the context of what's government's role and then what is not government's role.
So, great question. According to AAMC and the UC Mexis program, there's about 20,000 international medical graduates in the U.S. who have graduated in the last 10 years. And so a policy issue has to understand some of those graduates, unfortunately, have been out far too long, and they really can't, they would have to go through medical school all over again in order to be prepared for a residency program. However, there may be some retraining that they could get that would actually permit them to practice as a physician assistant or an ancillary practitioner, as you're suggesting. I think we need to look at that. Number two is we also obviously need to expand residency slots. there's already a shortage. There's many students U.S. graduates who can't get residency slots. And in fact, in Missouri, they passed legislation to allow students who didn't match in a residency to practice medicine as a PA would under an existing physician in the state of Missouri. That's how short the GME slots are. So from a governmental perspective, I think in California, we need to look at a Medi-Cal GME. As you know, Medicare pays the predominant share of residency training in the U.S. I think we need to look at expanding that. But California is one of 8 states that doesn't pay in the Medi-Cal program towards medical education. I think this is time that we visit some legislation. So one is looking at international medical graduates as a human resource that could perhaps be deployed, if not as physicians or practitioners, maybe as paraprofessionals, navigators, community health workers, skills that they have that they can easily recollect. Secondly is expanding GME programs so more U.S. students can get those. And then looking at the same type of reciprocity we have with Canada. You know, if I go and train in medical school in Canada, I can come back to do my residency in the U.S., but if I go to Mexico or Central America or South America, there is no reciprocity agreement. So we need to look at that reciprocity agreement so U.S. citizens who train abroad have an easier time coming back to the U.S. It's a comprehensive approach. It's going to take time and it takes study. Now, there's a couple other issues that are thorny issues for us as physicians. One is the scope of practice issue, and the second is the corporate bar. And I think as medicine and the healthcare marketplace evolves, we're going to have to figure out how that evolves because there is going to be a big tsunami coming against us on those issues, and we need to be very thoughtful about how we resolve those.
With regard to graduate medical education funding, that's a huge bugaboo for us. As you all know, the Medicare contribution to graduate medical education funding was frozen at levels from the 1980s. And there's really been no significant increase other than a few little local initiatives since that time. Now, there was some allocation for increased graduate medical education funding in the new tax bill. Whether we'll actually see that funding, is uncertain. But it's really more of a national policy issue than a state policy issue. We can get some expansion of primary care graduate medical education funding in the state, but that's not the entire solution to that issue.
Dr. Jesus, keep the microphone for 1 second. We've talked a lot about what physicians and how physician voices unify can create victories in the legislative process. Can unifying physician voices create victories that improve the lives of physicians or make it easier for physicians outside of the legislative process, and how does that work?
So absolutely. Our advocacy organizations are really our strength. As individuals, we have very little power or impact or effectiveness against big pharma, hospitals, third-party payers. We've had 2 recent victories that I could cite. Anthem Blue Cross published earlier in the year, end of last year actually, that they were going to cut reimbursement for anybody who performed a procedure at the same visit as an office visit on a patient. So as you all know, there's the -25 modifier that indicates you performed a procedure. The procedure is reimbursed at its full cost, and the office visit is paid at its full contracted cost. Anthem Blue Cross unilaterally determined that they were going to cut reimbursement for any -25 modifier procedures by 50%. As Californians, we took that issue to the AMA House of Delegates at the interim meeting in November and got support from around the country on this, and particularly from the Dermatology Academy. And AMA made policy objecting to this and immediately got in touch with Anthem. There was a series of negotiations, and Anthem came back and said, okay, we will only do a 25% reduction on the -25 modifier. With very little justification, and in actuality, they were using our coding system improperly, which, as you all know, the AMA owns. And after a series of negotiations back and forth, this past week, Anthem Blue Cross came out and said they are going to withdraw that proposal, and they now recognize the cost effectiveness of doing procedures at the same time as office visits, and they will not cut that reimbursement by 50% or 25%. So that was a big victory. That's hundreds of millions of dollars back into physicians' pockets. And it's also a big victory because I think as these payers implement these policies, I don't think they have any consideration of what the impact is on individual patient care. So if you're elderly and your caregiver or your children are bringing you to the physician's office to have to come back for multiple visits on things that could be done in one visit purely because of a payer's policy, it's inappropriate. Another example is on December 27th, Anthem published that they were no longer going to reimburse for anesthesiologists during cataract surgery if you were under age 65. So I found out about this in mid-January when one of the anesthesiologists at my surgery center came running up to me and said, "What are you doing about this?" And I'm like, "What am I doing about what?" And he shows me this policy, which I had never heard of. There had been no formal notification to either anesthesiologists or ophthalmologists that they were no longer going to cover the cost of an anesthesiologist during cataract surgery. So I immediately contacted our Center for Economic Services at CMA. Jody Black got on it immediately. Craig Kleiger, who's the executive director of the California Academy of Eye Physicians and Surgeons, got on top of it. We communicated with Anthem Blue Cross, and we really didn't get much of a response. That was going to be their policy. We also contacted eye societies around the country, as well as the American Academy of Ophthalmology, American Society of Cataract and Refractive Surgery. And after a great deal of to and fro, Anthem said, well, okay, we're going to change the policy. So as of February 1st, they changed the policy, and they said, well, they're just not going to pay for anesthesiologists providing conscious sedation. So clearly, Anthem didn't even understand what they were doing because they were essentially one and the same. So after a lot more to and fro, Anthem sent a letter out a week ago saying, well, we never implemented the policy, even though it's on their website, it's on their medical policy section of their website, and there was no reason for any physician not to believe it was being implemented until they received denials for an anesthesiologist's care. So as I said to Anthem, number one, you can't expect an anesthesiologist to render services and then find out after the fact that you're not going to pay for them because it's against a policy that you claim was not implemented. And as I said to various senators and congressmen when I was in Washington, they said, well, what are they supposed to do? I said, Anthem is promulgating the leather restraint form of anesthesia. You tie the patient down, you stick a needle in your eye, and you see what happens. So frequently when I'm talking to our legislators, I am very graphic, because you or I have a medical knowledge that the average layperson doesn't have. So you have to put things into painful terms for them so that they can empathize with what the patient's going to go through. So the bottom line is we have victory on both these issues, and it's because we have effective advocacy organizations. I want you to carry that message home to your fellow physicians. We need their participation as members of our organizations, or our effectiveness is diluted. And advocacy costs money. We need those dues dollars to advocate on behalf of our fellow physicians and on behalf of our patients.
We're going to give the last question to Dr. Sharma, and then we're going to take some questions from
Can I
the...
add something real quick?
You can.
Yeah. I agree with everything David said. That unified voice, regardless of specialty and regardless of affiliation, a medical group is critical for the reasons you mentioned. We mentioned MICRA earlier. That's another reason. And there's another piece here, which is we're going to need help. For those of us who are in solo and small practice, we're going to need to figure out how to aggregate, because we need a certain amount of sort of throw weight or critical mass in order to be able to transform our practices and find the capital to be able to do that. And CMA can accomplish that, I think, and LACMA as a local society. The other piece is really working with health plans. You know, one of our best partners in California is Kaiser, and certainly here in Los Angeles County, not just because you're here. You know, and it's because our fellow board members here. It's because it's a physician-led organization, and that's a really key thing. They're a large medical group. And there are other health plans. Many of you know, full disclosure, I'm on the board of directors of Blue Shield of California. When I joined Blue Shield, I vetted the organization because I know that amongst us, when someone goes to the health plan, we say they go to the dark side, right? And I saw that Blue Shield as a nonprofit health plan was very similar to Kaiser and where I trained, and the kinds of investments that Kaiser has made in community benefit, that Blue Shield has the same capacity to do that. They've already done that under, I have to take some credit on that, along with Dr. Sandra Hernandez, who's the other physician on the board at the time, was to invest in the organized medical groups for the ACOs, commercial ACOs, before ACA was implemented, in anticipation of the CMS ACOs. Number two, the 2% pledge that Blue Shield took in 2011, which was that it would set its margins at 2%, and anything above that would be rebated to the consumers. So it was the first plan to make those payments before the ACA required health plans to make those payments. And then number three, we're now looking at how to have Blue Shield invest in smaller practices, so that saving private practice is not just an exercise where we convene, but saving private practice is something we can say, this is our next step throughout the year, with health plans leading the way.
So with that, before we go to questions, Dr. Sharma, as a physician, what advice would you give to our colleagues for how physicians should be leading the conversation with our local communities, our state communities, and even as we think about sort of our AMA colleagues, sort of the national conversation on healthcare? How would you advise physicians to take part in that conversation?
So with regards to education and advocacy, with regards to how we do business and how we take care of patients, I think David hit it right on the head. You know, you have to make it very visceral for people to understand what it is that we do for a living, and how messy and how difficult it is to actually adjudicate health, do it sensibly, and then still provide the value add and cost containment that the organizations supporting us are looking for. So how does that work? Is that it works on many levels. It works, you know, at the educational level, it works at the local government level, and it works at the higher government level as well, and then of course with the health plans themselves. We know that all of these other institutions that in some way, shape, support us, there is a decoupling of understanding. And so our role really is that to make sure that if a policy is coming our way that really doesn't make sense for the patient or for us, that we have to, in graphic detail, go out there and say this doesn't make sense and why. A lot of times the reasons why bills are passed or why policies are engaged is because they think that they're adding a value. Take away the anesthesiologist for cataract surgery because chances are you can do it just with the local. We think that there's no value added there. Obviously, we can see that there's a counterfactual to that makes a lot more sense than what was the original proposal. So going forward, my advice is that we should be engaged in the social media and we should be engaged in popular press, because I think our perspectives are often spoken for by other people other than physicians. And when physicians aren't really the ones speaking out, you know, then what happens is that we start to look like some disconnected entity. It's the physicians, but actually we are your doctors. This is a very big difference, you know, when you actually think of sort of an us versus them model. These patients are our patients and we are their doctors. And so I think when we frame it that way, you know, then the idea that advocacy is protection makes a lot more sense to people, and that they realize that we're not just trying to defend our own pocketbooks and that we have some sinister motive, but we too are also engaged in the fair process of looking for what makes sense, you know, for quality, for access, and affordability.
Excellent. That was the best plug I've ever heard for CMA has a social media ambassadors program that you can sign up for on our website. So cmanet.org. All right, so I got questions there. That was the first question. I have about 15 minutes so that people don't miss their appointment. So we're gonna ask you to keep your question brief, not a whole lot of ramp up, and then we'll help to keep the answers brief as well. So question one's there.
Thank you. I'm Dr. Neskovic. I'm family physician and geriatrician for the last 29 years in this community, Glendale and Burbank area. And I'll tell you, who knows me knows that I'm one of the happiest guys, right, Emil? But 10 years ago, I got them EMR, and very good one. And I was happy for 5 years. And later on, I saw what's the catch. I need to spend more hours. I was going home 5:30, 6 p.m. Like Lee Iacocca said, you go home 6 p.m. for dinner. Now, last 5 years, I'm staying in my office till 7, 8, 10 p.m. And actually, I'm voting for you three gentlemen. You are so accomplished, professor this, professor that. Do you guys have families? Do you have enough time for all of this? Like, because it's taking too much time. Like, ignorance is a bliss. I didn't know. Medicare didn't pay me for half damn things. I didn't know how to code 99396. And what the heck, now I learned that, and that takes my time. And I need to document. You cannot say patient has diabetes. You need to document that you talk to them. Obesity, you need to document. What's the name? Cardiovascular screening. You need to talk to patients about them eating Mediterranean diet and avocado. You need to document. So this is taking our time. And 6 months ago, this is important, Glendale Memorial Hospital offered to physicians confidential questionnaire about stress. And I said, what the heck, I'm a happy guy. I will be the best, like 1% of the happiest doctors. Guess what? I was in 50th percentile. So 50% of doctors are happier than me. And I did month ago or a week ago, another same test. I said, let me see how I'm doing compared 6 months ago and now. Guess what? 75% of doctors are happier than me. This is awful.
We
Now,
need you to get to your question.
And I promised.
We
I
need you to get
promised-
to your question.
Okay, my question is coming.
Thank you.
Come on, my friend. My mother told me don't talk about politics and religion. This is all politics here.
I know.
did not hear one word. This morning, Athena Health, yeah, it's good EMR, a little bit better than mine. But my staff would quit on me. I wanted to change to Athena Health. They said, no, doctor, this is it. So I must, because of them, continue with my Lumeris EMR. Second point, I'm listening lecture about improving ET, and I thought I'm very good in that. Smart gentleman, he's selling his Tiger texting, which I can get on Google for free. Okay, now my question.
Okay.
I came here to write down something useful for my office. This seminar is called Saving Private Practice. And I'm sorry, you guys are a little bit self-serving. You, sir, Sacramento, liberal issues, whatever. You also want to be president of this or that. How about this? Who can help me? And there are maybe 50 doctors like that to make my medical assistant happier. And I paid her better than anybody, and she's still not happy. My receptionist, she's doing this not happy-go-lucky, be happy, smile. Why is that difficult for them to smile? Why? So my question is, please give me a small tip, like I'll give you now one tip. 10 years ago, I figured out that my lines in office are not adequate. Sometimes they go down with my charter cable, and I have Verizon cell phone. I said, can I get that black box? I heard, yes, I'm paying $22 a month. I would recommend everybody gets that. Plus in Costco, I bought for $120 5 cordless telephones. So each room has, my receptionist has that line 22, I call it. My medical assistant has, and me in any room I am. So this is my hospital and pharmacy line, and it works like charm. Also, when my charter cable goes down, it overflows so we can answer patients' phones.
Okay.
So I'd like to hear at least one useful tip to help my office.
You ready?
Thank you.
I got it for you.
I got it. I have 2 more points, but that's okay. That's just one tip.
Yeah.
Thank you. Okay.
All right.
We have never enough time and love.
I know.
Please think about it. And we are human beings are self-serving, man. Don't talk about you and your Sacramento thing. This is saving private practice. One useful tip, please.
So,
All right.
the irony of the whole thing is that the guy from Kaiser is going to try to help you. Right? So we actually have looked at this also, and all the pain points that you've described are the exact same pain points that we have, okay, which is that we're spending, for every 1 minute in front of a patient, we're spending 2 minutes, in front of the computer, okay? So how do you get anything done? Do you really need to document that you told a patient to quit smoking? Like, I mean, really? Of course, no, the answer is yes, you do. The question is that who around here doesn't think that smoking, is bad? But to your point, the one thing that we have used, and which makes for a very messy note but satisfies all the regulatory requirements, are templated notes. So for all the documentation that you have to provide, if you have that sort of pre-populated into your notes, then what happens is that you're not going to have to go back and do that. What you're going to be spending more time doing is just deleting things that you don't need, but ultimately the things that are going to be there for billing and coding purposes are there. And so that's what we do, and so that seems to help us the most.
All right.
Actually, I'll give
you got another one?
Couple,
All right, here we go.
Couple of specifics. So, three items for you to remember. One is HSAG, Health Services Advisory Group. Okay, what they are is they're contracted by Medicare to advise physicians how to prepare their practice for MACRA, for Medicare, MIPS, and as an extension of that, how to prepare their practice for transformation, because all payers are going to do what Medicare is doing. So hsag.org. Yeah. Number 2, LA Care. We were very fortunate to have Tom Horowitz on the board and now Stephanie Booth. Stephanie, where are you? And I appreciate that the time that both of them have dedicated to being on the LA Care board. Because of Tom's role on the LA Care board, when the economic stimulus provided money for physicians to purchase EMRs, he made sure that private physicians got a chance to get access to those dollars through the LA Care Regional Extension Center. So check in with Stephanie, because there has to be a second round of that. And then number 3 is looking at what LACMA can do for you. I know you're a member, but encourage other physicians to be members, because when we get the strength in numbers, we can actually get the resources to do technical support for practices.
All right. All right. Next question. I just want you to note that was 4. You asked for 1. You got 4.
I'll try to stick to 1.
All right.
One reason I think this saving private practice is extremely important is because without private practice, the guys with the money are just going to go up for the next highest level piece of fruit that they can pick and get rid of, so that everything gets cheaper, cheaper, cheaper. And so in that, the organized medicine suits all of us. It's good for everybody, including this particular conference. My question is, with power, we can actually get somewhere, but the most powerful of all would be to get the patients involved. And I can pretty well bet that we would not be going through a lot of this if they had to get reimbursed from the insurance companies instead of us doing the billing and doing all that. So I'm wondering, I don't plan to throw them back in the middle, because that would be completely unfair. But is anybody coming up with any ideas about how we can get the public involved with what's going on? Because I think if we had their voice behind us, it would be much easier.
Okay. There's an answer to that.
There is an answer to what you're saying. The president-elect is correct to not take the contracts. And so what we do is, if you're not contracted, the check does go directly to the patient instead of you chasing the money. And as far as so that's that.
Yeah. Okay. The other answer is, and it was mentioned earlier, right? The strategic involvement in social media, so that people recognize what's going on. And then the second thing is, and this is a Sacramento thing, it matters who your elected officials are. So our collective voice in trying to select or influence the gubernatorial election, because the gubernatorial election determines who becomes the head of the Department of Managed Care Services. Right now, we have a managed care services, quite frankly, that is run from a perspective of a health plan. We're trying to change that in this November. So we are having those discussions, but you got to have a partner that has an open mind to what you're talking about and why it's important. And right now, while Jerry Brown has been a fantastic governor on many things, on this regard, he has not been, from our perspective, that good or that responsive.